Hello and welcome to the CNBC Africa special focusing on the future of health in East Africa, courtesy of Forbes Africa and Phillips. My name is Charles Gitonga. The East African region is on course towards achieving universal healthcare coverage for its citizens in line with Sustainable Development Goal number 3. And what a better place to have this conversation than in the heart of the region, which is Nairobi. The Future of Health Summit, hosted by the continent's most influential business magazine Forbes Africa and technology company Phillips, brought together some of the brightest minds in East Africa's healthcare sector.
Health is a unique area where compassion, altruism, and economics combine in a single cause. By saving lives, we not only do something morally right, but also help build healthier, more prosperous, and productive communities. In our Constitution, Article 43, health is a right. It's guaranteed as a right. County governments since 2013 have played a very critical role in healthcare transformation by leading innovative efforts to improve the quality of healthcare while reducing its costs. I'm sure you've read about all the innovations that county governments have come up with. Places where we never had cesarean sections being done, they're being done in very remote areas in this country. Places where mothers were not delivering. It may sound like very basic from other countries, but in Kenya, it was that bad. So we are very happy that actually as a country and as county governments, we've really moved healthcare to a different level.
Primary healthcare is a very important subject to tackle, and we, as already indicated, are working together with the Kenyan government, with the Dutch government as well, with the UN, to really make sure that we create a platform where we have ideas, bring new innovative business cases to the forefront to really make a difference in that space. So Phillips has been working on that environment quite a lot, and we really dig deep in, even coming out of our comfort zone, say, okay, what do we need to do to really make it happen over there?
Sustainable Development Goal number 3 of the United Nations aims to ensure healthy lives and promote the well-being for all. In the last 4 years, Kenya's strategy to achieve this has changed dramatically with the devolution of healthcare among 47 counties. This means that county governments are in direct management of the sector.
County governments have continued to allocate an appreciable average of about 21% of their budget to health services. In the last 3 financial years, a total of about 200 billion out of 954 billion allocated to counties was specifically for health sector. And so there's resources, there's increasing resources that actually we can be able to utilize together with the private sector to improve the quality of healthcare, so that we begin to move away from the basics that we've been addressing in the first 4.5 years of county governments to now quality healthcare that we are talking about today.
The evolution of health services has had a very, very important and tangible impact because now initially health services was centralized. So most of the big officers in charge of health were at the national government. So closer supervision of what's taking place at the grassroots was not really taking place. Now the county governments are in place. They are able to see firsthand from a very close distance because of devolution to supervise and ensure that the health services are done in accordance to how they should be. We have seen a drastic improvement as far as that's concerned. Let me just give you an example. In the county where I come from, Isiolo, at the beginning of devolution, we only had, I think, about 2 to 3 medical practitioners or doctors who are in the whole county. You can imagine a county of almost 200,000 plus people. We had only 1 or 2 doctors serving the whole county. Today, because of the recruitments that we did and having taken more doctors, we have over 15, just in a period of less than 4 years. So that's a huge improvement in terms of bringing staff and experts in our hospitals.
Counties understand that universal health coverage and investment in health systems can accelerate both national and global efforts to ensure access to health care to anyone who needs it. The universal health care can help us galvanize progress towards achieving all the health-related sustainable development goals and ending preventable deaths, particularly amongst the most vulnerable populations, amongst the women, children, and adolescents. We can foster greater equity and empower countless individuals and contribute to a life of dignity for all.
Participants at the summit defined the future of health as technology-driven, accessible, and affordable.
What we see in Kenya over here, Phillips has been a leading partner for private sector as well as public sector in many ways. And we have been partnering, for example, with private hospitals, but also with the public sector. Recently, part of the MES program of the Ministry of Health as well, providing game-changing care to areas of the country which has been deprived of this kind of care as well. So critical care is one of them, for example. But specifically, when we come down to the community, they have very little choice. So there where you see, and I've been seeing that myself very often as well, is that if you go to a very remote area, this community, these people have no choice. So if they have nothing, they have no access to healthcare, they tend to go to the very far distances to seek that healthcare.
I think first of all, we need to recognize what the problem statement is. Every year, 1 million Kenyans go into poverty simply because of an out-of-pocket health shock. And if you look at Kenya, and if you look at the youth bulge and the demographic returns that this country and perhaps all of Africa can get, there are two primary game changers for this. One is effective and good education and skills building, and number two is access to excellent primary health care. Now, if we don't improve access to primary health care, what happens is your human development does not stay in line with the development that the country is making. And that is why I feel that by addressing the whole issue of the Sustainable Development Goal 3, and this is where all hands come to board. Right. The government leads, but it needs the United Nations family, it needs the private sector, it needs civil society, it needs faith-based organization, because the president of this country, and so has the First Lady, really pushed on the agenda of maternal and child health. And I believe that maternal and child health is the core of universal health coverage, particularly at the primary health care level. You improve maternal and child health, you reduce total fertility rates, economy starts to take off. It's a very direct correlation.
East Africa continues to struggle with the fight against HIV/AIDS, tuberculosis, malaria and non-communicable diseases. The International Finance Corporation estimates that in the next 10 years, Africa needs $25 to $30 billion in new investment to meet healthcare demand. Countries such as Kenya are taking a multi-agency approach to fill the gap.
It is about bringing different stakeholders from the private sector, where Phillips, the government of the Netherlands, have been really active partners. Germans are coming on board. Norway is considering it. Different companies coming on board. But it has a mix of the private sector, of government, of the United Nations family, and experts. The job of this partnership panel, which is actually being supported by McKinsey in terms of developing a business case, is we are going to have a secretariat. Now, this secretariat will be the best-in-class talent who will be seconded from the private sector to the United Nations, and they'll wear a UN contract for 2 to 3 years, non-extendable. The idea of this is that we have this talent pool which is working with the county governments, working with the national governments, working with the private sector to come up with a viable business plan. That business plan is the one that we will now look at. How do you finance it?
It is therefore critical to establish in Kenya an SDG partnership platform for transforming primary health care and achieving universal health coverage in Kenya by 2021, ensuring that in this platform, both national and county governments are actually partnering to address these issues and bringing on board the private sector. And the platform will champion the public-private collective action and look into opportunities for accelerating universal access to primary health care services by in particular addressing the gaps in human resources, healthcare financing, essential medicine, medical supplies, health information, and use of technology.
If technology is indeed the future of health, a sizable amount of investment will need to be directed towards innovation in electronic care records and remote monitoring of patients, among other areas.
The role of technology is well known. You remember how mobile phones revolutionized Kenya. Now we can be able to talk to anybody almost anywhere. Even having said that, we still face challenges because particularly in northern Kenya, there are areas where mobile coverage is still not as it should be. Right. In my county, for example, I think still over 60% of the land area is still not yet fully covered. So it becomes a challenge to deploy technology in those areas. But nevertheless, I think it is going to be quite effective if the technologies that have been described here could be applied also in our counties, right, to make the cost of travel, particularly for patients who live in far-flung areas, to be able to be treated wherever they are.
The patient journey needs to be minimized, and that patient journey can only be minimized by technology. Right now, it is cruel. In some of the counties, for a woman who gets into complications and comes to give birth at a facility, let me tell you, that distance that she may have traversed is 200 to 300 kilometers, during which she may have died, and so would the child. We need to change that game. And what we are seeing is when we went into these counties with the private sector, the United Nations family, UNICEF, UNFPA, WHO, together with the county governments, the national government, the private sector like Phillips, GlaxoSmithKline, Merck, Safaricom, Huawei, Kenya Healthcare Federation, what we've seen in counties like Mandera, which has the highest maternal mortality in the world, that figure has dramatically changed. You know, Mandera, Vajir, Marsabit, Lamu, Isiolo, these are places which were like a death sentence for a woman giving birth. They account for 50% of the maternal deaths in Kenya. That figure has dramatically changed. And what we've seen is what partnerships, what good policy, and what good political will can do.
We, as Phillips, have an innovation lab here in Nairobi, so in the Research Innovation Center, where we really, together with Kenyan scientists, researchers, really dig deep into the community and to understand the needs over there, but also to appropriately look at technology. Right. What kind of technology is used and can be used in the areas where we talk about. Solar power is one of them. Yeah, and you need to design it very well, but you also have to look at the community how to use it.
Besides investment in technological hardware and software, the region is also in need of personnel. That need can be met through training of community health workers.
That Kenya needs to create 1 million new jobs every year for the next 10 years, given the youth pouch. I would be much more impressed if when Deputy Governor Guled says, we have trained 10,000 community health workers who are young people and are technologically savvy. They can go from home to every home and community. It's not the number of doctors. We will never keep pace with the number of doctors. Africa is 50% short of doctors. You need task shifting. You need smart young people who can go to the remotest of places, do those basic tests, vaccinate children, and get those results back.
Time for a short break now. When we come back, we take a look at how the mobile phone is advancing healthcare in Rwanda. Don't go too far. Welcome back. Advancement of mobile technology has seen devices being used across several sectors of the economy, among them healthcare. In Rwanda, Babel is reaching over 500,000 people via this platform.
All of our technology in the UK and Europe is based on a smartphone. So the first thing we realized that actually a smartphone wasn't going to do it across East Africa. So we've developed our technology on a basic feature phone. So obviously we don't have all the functionality that we have on our smartphone. On a smartphone, it stores your medical records, it stores all of your video and audio consultations with doctors and nurses. It has a chat box function now in terms of you being able to get very good healthcare advice. And it has digital pharmacy function as part of it as well. And that technology is growing very fast every day as we speak. So how do we take that functionality and put it on a basic feature phone was our first challenge.
To address the barriers associated with low smartphone penetration in rural Rwanda, Babel has developed a USSD code that's adaptable to feature phones. This enables patients to perform doctor consultations and match medical prescriptions electronically.
Delivering a digital healthcare solution is not just about connecting a nurse and a doctor with a patient in a rural area. You've actually got to do everything that a physical hospital normally does. And the first thing a hospital does is actually register you and verify you and check that you're eligible for care. So we have to do that on a basic feature phone. So that's why we're linked into NIDA. And then NIDA will be linked into a national database of those patients who are eligible for the universal healthcare scheme across Rwanda.
The quest by Babel to integrate into the national health system in Rwanda serves as an example of scalability of tech solutions in healthcare. But what does it take?
From a scalability perspective, it's about ensuring you have a model that will work wherever you are. Now, there is not necessarily one size fits all, so you have to have multiple ways of accessing that model. And we've heard of it, whether it's on a smartphone, whether it's on a computer, whether it's on USSD. The service that you get is slightly different as you drop down in the technology, but you have to have access to it, and as universal access as you possibly can. And then for the likes of us, we've built our solution in the cloud. It's a completely scalable solution built on virtual machines, whether we're going to access it from the UK, from Nairobi, from Isiolo, from Rwanda, Uganda, Tanzania, wherever. It's there. So you build your solution and you work out from there.
Kenya is data rich but information poor. It is difficult for a patient or a user to access their medical records wherever they go, and this makes healthcare very expensive because of repetitive examination and prescription that goes on and on and on. So is there an elaborate plan in the system, in the health industry, that can help the patient to access the medical records wherever they are to make the cost of healthcare affordable and cheaper?
You've got to weigh up that balance between securing that data and providing access to it. And what we've tried to do is ensure that we can provide access to it from whatever device our consumers are coming in at. But we've got multiple layers of security and encryption to make sure that data is secure. Now, by the very nature, that then makes it difficult to start sharing, and because there's lots of disparate systems out there. I'm sure all the counties have got their own system, central government has got their own system, private companies have got their own system. It's an actual nightmare trying to pull all those together, and the person that cracks that one is going to make everybody smile.
Individually, counties are purchasing the softwares that are in the market. I've seen quite a number of companies advertising and offering to sell medical, software system where records and everything can be managed within one particular county. But the challenge, of course, is, as Tony said, we don't have right now. The nightmare is how do you join the whole country and all these hospitals. Probably that's what we need to invent. But technologically, I think it's not difficult. They're already there in the market.
To encourage investment in East Africa's healthcare, proper regulatory frameworks are needed.
Regulation is important. We need to make sure that the market is regulated properly, but we should not over-regulate it as well. So we have seen, for example, in Kenya in the past, that we have to address all kinds of boards to really get your product either registered, or being used, or import, etc. And that has been changing now. So Kenya has been developing a one-stop shop whereby we can actually register one product so that we don't have to go fight a different kind of boards. That's important, to make sure that you have one harmonized system. And that should actually be deployed throughout Africa.
My question is, as an association, one of our core mission is to ensure that quality of healthcare is delivered to the Kenyans. And one of the key areas that we are looking at right now is an ICT platform. The only problem that we have in terms of bringing the stakeholders to the discussion, bringing our doctors to the discussion, is that we do not have regulations. We have an e-health policy that has been in development, continues to be in development. We have no communication about it. How far is it? What is the government doing in terms of this? Do we need to form a regulatory body that will work together with the ICT communication in terms of just regulating e-health? Because let's face it, the 6,000 healthcare workers, doctors in this country will not bridge the gap even in the next 50 years. But we can use the ICT platform in terms of telemedicine, teleconsultation, teleradiology, and use the skill that is available to be able to have excellent coverage in the country.
I sit together with Sid on the SDG 3 platform, where the Minister of Health also is a member. And the issue of ICT involvement in healthcare has come up several times, and I'm sure it's something that is on the table being discussed. I'm sure the Health Practitioners Association also definitely has something to contribute as far as that's concerned. So to do that on a national level, at the county level, of course, we'll be guided by that, even though there will be also diversity in as much as the counties are concerned.
The regulation ought to be broad enough to accommodate incentives across the board, from investors to health workers.
You know, incentives matter. If we were to immunize every woman and child in Kenya, we have won 30% of the primary healthcare battle because of preventable diseases that could be stopped from happening. What does that mean? India, with a population of about 1.3 billion, just recently eradicated polio 5 years ago. And India's complexity, ladies and gentlemen, please don't even begin to compare it with Kenya. It is widely, very, very complex. And if in that environment it's possible to do it, why not have a Grammys award kind for the governors and say, look, you ensure 100% immunization coverage, this is your reward. Incentives matter. Simple economics. You want people to do something, incentivize it. You don't want them to do it, tax it.
In addition to regulation and incentives, governments need to honor the Abuja Declaration. In April 2001, the African Union countries set a target of allocating at least 15% of their annual budget to improve the health sector.
I think the Abuja Declaration is an excellent declaration. It gives an objective to African governments to reach. But clearly, the socio-economic environment doesn't permit that to happen. That is where we need innovation. That is where we need partnerships to come into play. Now, let me give you an idea. What if? Are there any economists in this room? No. Okay. So what if we took we take the top 10,000 shilling transaction that we do on M-Pesa, and we have 100 shilling charge to that, which means that I have said to you 10,000 shillings. I pay 50 cents, you pay 50 cents, and we prorate this all the way upwards. Imagine that anybody landing in Jomo Kenyatta Airport, arriving, departing, or transiting, pays a $1 or 100 shilling Robin Hood tax. My economists at UNDP actually figured it out, that if we were to do this, Kenya, if let's say we try to do this in India, it will take 4 to 5 years. If we try to do this in Kenya, it will take 4 to 5 months. Why? Because Kenya is well ahead of many countries all over the world in terms of cashless mobile financing mechanisms. We figured out that Kenya can actually raise a revenue of close to $10 million a day, which is $1 billion shillings a day, if we can ring fence it.
A key concern coming out of the conversations here has to do with the availability of data and incorporation of that into new or existing solutions. Nonetheless, tech will still continue to play a pivotal role in penetration of healthcare services in the region. My name is Charles Gitonga. Thank you for watching.